Here's something nobody tells you. When doctors see a hemoglobin number that's dangerously low, they don't rush. They pause, and that pause, it can literally save a life. If you're watching this, chances are you or someone you love just heard words like, "Your HB is low," or worse, "Your HB is very low," and your brain immediately goes there. Am I going to need blood? Tablets? Surgery? How bad is this really? Honestly, that moment is terrifying. I've seen it. Patients sitting quietly, nodding along, while inside their head everything is screaming. So before we talk about iron tablets, IV iron, or transfusions, we need to talk about what actually happens first. Because treatment doesn't start with a needle. It starts with a decision. Here's what most people assume. Low hemoglobin equals iron tablets. Done. But that's not how medicine works. And thank God for that. Think of hemoglobin like a house fire alarm. When it goes off, the noise is loud, scary, urgent, but the alarm doesn't tell you why there's smoke. Is it burnt toast? Or is the whole kitchen on fire? Doctors treat low HB the same way. Before giving anything, they ask 4 quiet but critical questions. How low is the number? Exactly. How fast did it drop? How is the patient feeling right now? What's happening inside the body that we can't see yet? And here's the twist most people don't expect. Sometimes the number looks horrifying, but the person sitting in front of you looks okay. That's where medicine becomes judgment, not math. Let me paint a picture. A patient walks in. No dramatic symptoms. They're tired, yes. Short of breath on stairs, maybe. But they're talking, sitting, joking, even. Lab report comes back. Hemoglobin, 5.8 GDL. That's critically low. Now, if you watched our previous episodes, you already know how serious that number is. So the question becomes, why isn't this person collapsed? Here's what's happening behind the scenes. When HB drops slowly over months, the body adapts. Heart pumps harder, breathing gets deeper, blood vessels stretch and compensate. It's like living in a city with constant traffic noise. At first it's unbearable. Then one day, you don't even notice it anymore. But adaptation is not safe. It's borrowed time. This exact concept is discussed in multiple hematology reviews, including a 2020 review in the Lancet Hematology, which emphasized that symptom severity does not always match HB levels, especially in chronic anemia. That's why doctors don't panic, but they also don't relax. This might surprise you. Blood transfusion is not the first choice in many low HB cases, even when numbers are scary. Why? Because transfusion is powerful medicine, and powerful medicine always comes with risk. Modern guidelines, including the 2019-2023, WHO and AABB recommendations, consistently stress restrictive transfusion strategies in stable patients. Translation? If you're stable, breathing okay, not bleeding actively, doctors think twice. They ask, can we correct this safely without transfusion? Because transfusions can cause allergic reactions, iron overload with repeated use, fluid overload, especially in older patients. So that pause we talked about earlier, that's doctors protecting you from unnecessary harm. Here's something most patients never hear out loud. Treatment success isn't about how fast hemoglobin rises. It's about how safely it rises. Push it too hard, too fast, and the body struggles. Go too slow and organs suffer. That balance? That's the art of medicine. And this is exactly why two people with the same HB number may get completely different treatments. Same lab, different bodies, different stories. So before we talk about iron tablets, 4 iron, or blood transfusions, we needed this foundation. Because now you understand something crucial. Low hemoglobin isn't treated by a formula. It's treated by judgment, timing, and context. And in the next phase, we'll finally open the medicine cabinet. Tablets, drips, blood, what each one really does, who actually needs what, and why taking the wrong treatment, even with good intentions, can make things worse. Stay with me, this is where it gets practical. Here's the uncomfortable truth. Two people with the same hemoglobin number can walk out of the hospital with completely different treatments. And no, it's not guesswork. It's medicine thinking 3 steps ahead. When people hear treatment for low HB, their mind jumps straight to extremes. Blood bags, hospital beds, that sharp hospital smell nobody likes. But let's slow this down. Because treatment for low hemoglobin isn't a ladder where doctors always start at the bottom and climb up. It's more like choosing the right key for the right lock. Use the wrong one? You don't just fail to fix the problem, you create new ones. So now we're going to calmly unpack the 3 medical treatment paths doctors use, and more importantly, why they choose one over the other. No panic, no exaggeration, just clarity. Almost every medical treatment for low hemoglobin falls into one of these 3 categories. Oral iron tablets, intravenous blood transfusion. That's it. But here's the part most people miss. These are not levels of severity. They're tools for different situations. A 2021 review in Blood Advances emphasized that anemia management should be cause-specific and patient-specific, not number-driven alone. Translation? The HB number opens the door. The patient's condition decides what happens next. Let's start with the most common one, iron tablets. They're cheap, they're easy to prescribe, and they're often blamed when things don't improve. But iron tablets aren't weak. They're just slow. Think of oral iron like planting a tree. You don't water it today and expect shade tomorrow. It needs time, consistency, and the right conditions. Doctors usually choose tablets when the patient is stable, there's no active bleeding, the gut can absorb iron, HB isn't falling rapidly, in fact. Multiple studies, including a 2019 meta-analysis in the American Journal of Medicine, show that oral iron can raise HB by approximately 1 to 2 gdl over 4 to 6 weeks when taken correctly. That's not failure. That's physiology. The real problem? Most people don't take it correctly, or long enough, or with the right expectations. We'll go deep into that in the coming discussion. But for now, remember this. Iron tablets are not a quick fix. They're a foundation. Now let's talk about IV iron. This is where fear and fascination mix. A drip, a hospital chair, iron going straight into the bloodstream. Sounds intense, and yes, it's powerful. 4 iron bypasses the gut completely. No absorption issues. No waiting for intestines to cooperate. Doctors consider IV iron when oral iron fails or causes severe side effects. The patient has gut diseases like IBD, celiac, HB is low, and needs faster correction. There's chronic blood loss that tablets can't keep up with. According to a 2020 review in the British Journal of Hematology, 4 iron can raise hemoglobin faster and more predictably than oral iron in selected patients. But, and this matters, it's still not an emergency treatment. IV iron doesn't work in hours, it works over days to weeks. So when people ask, why didn't the doctor give 4 iron immediately at HB 5.5? The answer is simple, because sometimes even IV iron isn't fast enough. That's where the 3rd path comes in. Blood transfusion is not nutrition, it's not supplementation, it's replacement. You're not helping the body make more hemoglobin. You're giving it hemoglobin directly. That's why transfusions work within hours, not weeks. Doctors reserve transfusions for situations like active bleeding, severe symptoms, chest pain, breathlessness at rest, confusion, hemodynamic instability, critically low HB with risk to organs. Modern transfusion guidelines, including AEBB 2019-2023 updates, recommend transfusions primarily when benefit clearly outweighs risk, because transfusion is life-saving, but not harmless. That's why you'll often hear doctors say, we'll transfuse just 1 unit and reassess. Not 2, not 3. 1 only, that's intentional. It reduces complications and respects the body's limits. Here's a fact most people don't know. These treatments are not mutually exclusive. A patient might receive 1 unit of blood to stabilize, followed by 4 iron to rebuild stores, then oral iron for maintenance. That's not confusion. That's strategy. A 2022 clinical review in transfusion medicine reviews highlighted that combination therapy reduces repeat transfusions and improves long-term recovery. Think of it like emergency cash plus a monthly salary. One saves you today, the other keeps you safe tomorrow. Here's where I'm going to be blunt. The biggest mistake patients make is self-directing treatment. Starting iron without knowing the cause. Demanding transfusion just because the number is low. Stopping treatment the moment HB improves slightly. Doctors see this all the time, and it's why anemia keeps coming back. Treatment isn't about chasing a number. It's about fixing the system that failed. So now you know the landscape. Iron tablets, slow builders, IV iron controlled accelerator, blood transfusion emergency rescue. But here's the real question nobody answers clearly. Why do so many people fail oral iron? Why does it upset the stomach, cause constipation, or just not work? And more importantly, how do doctors optimize oral iron so it actually raises HB? That's where we're going next. In the next discussion, we'll zoom in on iron tablets, what works, what doesn't, and why most people are unknowingly sabotaging their own recovery. Stay with me, this part changes outcomes. Iron tablets don't fail because they're weak. They fail because almost nobody is taught how to use them properly. And that misunderstanding alone keeps millions of people anemic. For years. After everything we just walked through, one thing should be clear. Iron tablets aren't the lowest treatment. They're the longest one, and that's where people struggle. Because slow progress feels like no progress. Especially when you're already exhausted, breathless, and just want to feel normal again. I've heard patients say things like, I took iron for 2 weeks. Nothing changed, or it made me sick, so I stopped, or the most heartbreaking one. I thought it wasn't working, so I gave up. And look, I get it. When you're tired all the time, waiting patiently feels impossible. Let's be honest for a moment. Iron tablets are probably the most blamed medication in anemia care. They're accused of not working, hurting the stomach, causing constipation, turning stools black, making nausea worse. And here's the uncomfortable truth. Most of those complaints are real. But they're also predictable and often preventable. A large 2021 review in JAMA Network Open pointed out that non-adherence to oral iron exceeds 40 to 50%, mostly due to side effects and unrealistic expectations. So the problem isn't iron, it's how it's given and how it's taken. This is where things quietly go wrong. For years, iron was prescribed like this: high dose, multiple times a day, every single day. Sounds logical, right? More iron in equals more hemoglobin out. But the body doesn't work like a sponge. It works like a gatekeeper. When you swallow iron, your gut decides how much to absorb. And when iron doses are too frequent, the gut releases a hormone called hepcidin that blocks absorption. Yes, blocks it. So ironically, taking iron too often can make it work worse. This is an opinion. This is backed by physiology and research. A landmark 2019 study in the Lancet Hematology showed that alternate-day iron dosing improved absorption and reduced side effects compared to daily high-dose regimens. That study quietly changed how many hematologists prescribe iron today. Let's talk about the stomach issues. Iron is irritating, it's metallic. It changes the gut environment. So when someone takes high doses on an empty stomach, multiple times a day the gut reacts. Nausea, burning, constipation, sometimes diarrhea. And here's what most people don't realize. Those side effects don't mean the iron is too strong. They mean the strategy is wrong. Doctors who manage anemia daily often adjust dose, timing, frequency, formulation, not because iron is dangerous, but because the gut is sensitive. A 2020 review in Clinical Gastroenterology and Hepatology emphasized that lower dose iron regimens significantly reduce GI side effects while maintaining HB response. Less force, more finesse. This one is subtle, but critical. Most people judge iron tablets by how they feel, not by blood tests. And that's a trap. Hemoglobin rises slowly. Symptoms lag behind numbers. So someone might take iron for 3 weeks, feel slightly better one day, worse the next, and decide it's useless. But biologically, something important is happening. The bone marrow is waking up. Iron stores are being rebuilt. Red cells are forming quietly, invisibly. You don't feel that process, but it matters. Doctors track response with repeat blood tests, not mood or energy alone. That's why stopping iron early is one of the most common reasons HB never fully recovers. Here's where everyday habits quietly interfere. Iron absorption drops when taken with tea or coffee, milk or calcium, antacids, certain medications, yet people swallow iron tablets with morning tea every day. Not because they don't care, but because nobody explained it properly. Vitamin C, on the other hand, boosts absorption. A simple squeeze of lemon, a piece of fruit. That's it. A 2022 nutritional review in Nutrients confirmed that vitamin C significantly enhances non-heme iron absorption, especially in plant-based diets. Small changes, big difference. Now, this part matters deeply. Sometimes iron tablets genuinely don't work, even when taken perfectly, and that's not failure. That's information. Conditions like ongoing blood loss, chronic inflammation, malabsorption disorders, certain chronic diseases can block iron's effect completely. Doctors call this functional iron deficiency. Iron is present, but trapped. In these cases, persisting with tablets alone is like pouring water into a sealed bottle. This is when doctors step back and reconsider the plan, not because the patient failed, but because the biology demands a different approach. Let's pause on something human. Being told to just take iron can feel dismissive, especially when you're barely getting through the day. Patients often feel unheard, unseen, like their suffering is being minimized. That emotional gap is real, and it's one reason people stop treatment quietly without telling anyone. Good anemia care isn't just about iron levels, it's about trust. When patients understand why something is slow, they're far more likely to stick with it, so now the picture is clearer. Iron tablets can work well, work gently, and work safely. But only when the strategy fits the person. They're not useless. They're not magic either. They're a tool, one that demands patience, context, and monitoring. And sometimes, they're simply not enough. Which brings us to a situation that confuses even experienced doctors. What happens when someone's hemoglobin is dangerously low, say 5 or 6, but they're walking, talking, and seem fine? That's not rare, and managing it requires some of the most careful judgment in medicine. That's the story we need to unpack next, because this is where mistakes can cost lives, and thoughtful decisions can save them quietly. IV iron looks like a shortcut, but shortcuts only work when you actually know where you're going. Used at the right moment, it can change everything. Used blindly, it can quietly backfire. After everything we've uncovered so far, one truth should be sitting heavy in your mind. Iron tablets demand patience. And patience isn't always available. Some bodies can't wait weeks. Some situations don't allow trial and error. And some people do everything right. Yet hemoglobin barely moves. That's when the conversation shifts. Not in panic, not in defeat, but with intent. This is usually the moment a doctor leans back, looks at the full picture, and says something like, "All right, let's consider IV iron," and suddenly the room feels different. Let's acknowledge the obvious. A drip feels serious, there's a chair, a cannula, monitors beeping quietly in the background. It feels like you crossed an invisible line from mild problem to something big. But here's the grounding truth. IV iron isn't about severity, it's about efficiency. Think of oral iron like mailing a letter. 4 iron is a courier dropping the package straight at the door. Same destination, different route. This part is important, so let's slow it down. 4 iron delivers iron directly into the bloodstream, bypassing the stomach, the intestines, absorption barriers, inflammation-related blocks. From there, iron is taken up by bone marrow, liver storage sites, cells actively producing red blood cells. It doesn't magically turn into hemoglobin overnight, but it removes the biggest obstacle, access. A 2020 review in the British Journal of Hematology showed that IV iron leads to more predictable hemoglobin rises in patients where oral iron fails, especially in chronic disease and inflammatory states. Predictable matters, because predictable is safer. Here's where judgment comes in again. 4 iron is often considered when oral iron causes severe side effects. HB is low and needs faster correction. There's poor absorption, IBD, celiac, post-surgery gut changes. Chronic blood loss outpaces tablets. Inflammation blocks oral absorption. Notice something? This isn't about impatience. It's about biology refusing to cooperate. And when biology says no, medicine adapts. This is where expectations quietly get people into trouble. Many assume 4 iron works like blood transfusion. It doesn't. You don't walk in at HB6 and walk out at HB10. What actually happens is subtler. Iron stores refill first. Bone marrow responds next. Hemoglobin rises steadily over days to weeks. A 2021 study in Blood Advances highlighted that HB response after 4 iron typically begins within 7 to 10 days, with continued rise over several weeks. So if someone gets 4 iron and checks HB 2 days later, disappointment is almost guaranteed. 4 iron is fast, but not reckless. This part surprises people. If the 4th iron works so well, why not give it to everyone? Because medicine doesn't reward overuse. 4 iron is safe, modern formulations especially, but it's still a medical intervention. Possible risks include infusion reactions, low blood pressure during infusion, rare allergic responses, iron overload if misused. Serious reactions are uncommon, especially with newer preparations, but doctors respect the risk, not fear it. A 2019 safety analysis in drug safety confirmed that serious adverse reactions to modern IV iron are rare, but emphasized proper patient selection and monitoring. That's why 4-iron is often given, in controlled settings, with observation, with clear dosing calculations, not casually, not impulsively. Here's something that often confuses patients. Why am I getting multiple infusions, or why only one? IV iron dosing isn't arbitrary. Doctors calculate body weight, current HB, target HB, iron stores deficit. Then they decide whether to give a single large dose or smaller doses over multiple sessions. This isn't indecision. It's precision. A 2022 review in Transfusion Medicine Reviews stressed that individualized IV iron dosing improves outcomes and reduces unnecessary repeat treatments. Less guesswork. More planning. Here's where things connect back to what we discussed earlier. 4-iron often works best as part of a sequence, not a solo act. A patient might receive blood to stabilize, then IV iron to rebuild, then oral iron to maintain. Each step has a role. Skipping one can undo the others. That's why doctors often say things like, "This isn't the finish line. It's the bridge," because IV iron builds capacity, it doesn't fix the underlying leak. Let's step away from labs for a moment. Many patients describe something subtle after the 4th iron. Not euphoria, not instant energy, but clarity. Breathing feels easier, stairs feel less cruel. That constant heaviness starts to lift. Not dramatically, gradually, and that gradual improvement often restores something more important than HB numbers: hope. Here's the critical truth. 4-iron fills the tank. It doesn't stop the leak if blood loss continues. If inflammation remains unchecked, if nutrition is ignored, hemoglobin will fall again. That's why good doctors always ask, why did we get here? And that question leads us to one of the trickiest situations in anemia care. Someone whose HB is dangerously low, numbers that make clinicians uneasy, yet the person sitting in front of them looks okay. Not collapsed, not gasping, just tired. Managing that balance between numbers and reality is where medicine becomes deeply human. That's the scenario we need to sit with next, because it's where the wrong move can do harm, and the right one can quietly save a life. Blood transfusion isn't a shortcut. It's a seatbelt. You only use it when the crash is already happening. And when it's used right, it doesn't just raise hemoglobin. It buys time. By now, one thing should feel very clear. Medicine doesn't rush without a reason. Iron tablets take patience. 4-iron builds momentum. But sometimes, neither is fast enough. There are moments when the body is running on fumes. Organs are compensating. The heart is working overtime. And that's when doctors stop debating strategy and start thinking about survival first. That's where blood transfusion lives, not as a routine step, but as a controlled, deliberate intervention. Let's be honest, the word transfusion hits differently. People don't imagine recovery. They imagine crisis. Hospital beds, urgent voices, family members waiting outside. And that emotional weight is real. But here's the grounding truth. Blood transfusion doesn't mean the situation is out of control. It means the team is preventing it from becoming one. Blood transfusion does one thing, and it does it immediately. It delivers ready-made hemoglobin. No digestion, no absorption, no waiting for bone marrow to respond. Oxygen delivery improves within hours. That's why transfusions are used when HB is critically low and symptoms are severe. There's active or ongoing blood loss, organs are at risk, the body has no reserve left according to consolidated guidelines from AABB and WHO 2019-2023. Transfusions are recommended when clinical condition, not just numbers, indicates danger. Numbers open the conversation. Symptoms close it. You might remember Nancy. She was the one who kept telling herself, "I'll rest after this week." Busy job, constant fatigue, dizzy spells she brushed off. By the time she reached the hospital, her HB was 5.2 GDL. She wasn't dramatic. She wasn't panicking, she was quiet. Doctors noticed her heart rate first, then her breathing, then the way she paused mid-sentence. This wasn't about iron anymore. 1 unit of blood was transfused, slowly, carefully, not to fix, anemia, but to stabilize her body so it could survive the repair process. Nancy later said something powerful. "I thought accepting blood meant I had failed. In reality, it meant she gave her body a chance to recover." This detail matters more than people realize. You'll often hear doctors say, "Let's transfuse 1 unit and reassess." Not 2, not 3, 1 only. This approach is intentional. A 2021 review in transfusion medicine showed that single-unit transfusion strategies reduce complications without compromising outcomes in stable patients. Doctors watch symptoms, heart rate, blood pressure, oxygenation. They let the body respond before deciding anything further. Because transfusion isn't about chasing a perfect number. It's about restoring balance. Helen's HB was 6.1 grams DL. On paper, alarming. In person? She was walking, talking, even smiling. Some family members questioned why transfusion wasn't immediate. But Helen had something important: stable vitals, no chest pain, no breathlessness at rest. Doctors paused. They chose IV iron first. Watched closely. Prepared transfusion as a backup, not a reflex. And that decision mattered. Helen avoided unnecessary exposure to transfused blood, rebuilt her own hemoglobin, and recovered steadily. Sometimes not acting immediately is the safest action. Now let's be very clear. There are moments when hesitation becomes dangerous. Transfusion is urgent when there's active bleeding, HB is critically low with organ stress, the patient is confused, breathless at rest, or in shock, heart disease is present, and oxygen demand is high. In these cases, delaying transfusion isn't caution, it's risk. A 2020 clinical consensus in the New England Journal of Medicine emphasized that restrictive strategies must be abandoned in the presence of tissue hypoxia or instability. Context always wins. Similarly, the case of Priya that had heavy menstrual bleeding for years. She normalized exhaustion, normalized dizziness. Her HB finally dropped drastically. By the time she reached care, her heart was struggling to compensate. Doctors didn't debate options. Transfusion came first. IV iron followed days later. Long-term correction came after that. That order mattered. Transfusion didn't solve Priya's anemia. It saved her organs long enough for the real treatment to work. Later, she said something many patients echo. "I thought the transfusion cured me. Then I realized it gave me time to heal." Blood transfusion is safe, but not casual. Possible risks include allergic reactions, fever, fluid overload, rare immune complications. Modern screening has made infections extremely rare. Still, doctors respect transfusion because respect keeps it safe. That's why consent is detailed. Monitoring is constant. And unnecessary transfusions are avoided. Not because blood is dangerous, but because it's powerful. Rachel, whom we talked about in the first video of the Hemoglobin series, felt amazing after transfusion. Energy returned. Color came back. Life felt normal again. So he stopped follow-up, stopped iron, stopped investigating the cause. 6 months later, she was back. Same symptoms, same story. Transfusion had helped him feel better, but it hadn't fixed why he was anemic. That's the trap. Blood transfusion treats the consequence, not the cause. Without follow-through, anemia always returns. Here's a rule doctors rarely say out loud. Transfuse to stabilize. Treat to recover, monitor to prevent relapse. Skip any step, and the cycle repeats. That's why transfusion is often paired with 4-iron, oral iron, cause-specific treatment. It's never meant to stand alone, so now the landscape is complete. Iron tablets build slowly. 4-iron accelerates repair. Blood transfusion rescues when time runs out. Each has a place. Each has limits. And now comes the part people think is simple, but isn't. Food, diet, natural recovery. Because what you eat after treatment can either support everything that was done, or quietly undo it all. That's where attention shifts next from hospital decisions to everyday choices that decide whether hemoglobin stays up or slips back down. Hemoglobin doesn't crash loudly. It slips down quietly, while life feels normal again. And by the time symptoms return, weeks or months are already gone. After food choices settle into daily life, something interesting happens. People relax. Energy improves. Color returns. Stairs feel manageable again, and that relief is earned. But it's also where risk sneaks back in. Because feeling better creates an illusion. Maybe the problem is gone. That assumption has ended more recoveries than bad medicine ever has. Doctors know this pattern well. Patients disappear right when things start working. There's a quiet moment that defines long-term recovery. It's when the doctor says, "Let's repeat your blood tests." And the patient thinks, "But I feel fine." That gap between how you feel and what your blood is doing is where anemia hides. Hemoglobin reflects what happened weeks ago, not today. So when HB starts falling again, the body hasn't complained yet. It's still compensating, still adapting. That's why monitoring isn't pessimism, it's foresight. A 2021 review in Blood emphasized that regular follow-up testing significantly reduces recurrence of anemia, especially after moderate to severe cases. Numbers don't replace feelings. They reveal what feelings can't sense yet. Here's a detail most people never hear clearly. Hemoglobin is the headline, but it's not the full story. Doctors also look at ferritin, iron stores, MCV and MCH, red cell quality, reticulocyte count, bone marrow response, because HB can look normal while iron stores are still empty. That's how relapse starts. A 2020 hematology guideline review showed that normal HB with low ferritin predicts future anemia if supplementation stops too early. In other words, feeling normal isn't the finish line. Rebuilding reserves is. Helen almost skipped her follow-up. She felt good. She was busy. Life had restarted. But her doctor insisted on one more check. HB looked fine. Ferritin didn't, so supplementation continued gently, deliberately. That decision kept her from sliding back months later. Helen once said, "I didn't realize recovery had layers." That sentence says everything. Now comes a sensitive area. Supplements. People often assume, if iron helps, more will help more. That thinking gets people into trouble. The iron is essential. But excess iron is not harmless. That's why doctors are cautious with dose, duration, combination supplements. A 2019 safety review in the American Journal of Clinical Nutrition warned that unsupervised long-term iron supplementation can lead to iron overload, especially once HB normalizes. Supplements are tools, not insurance policies. Used blindly, they create new problems. Nancy did everything right early on. But when her energy fully returned, she made a quiet mistake. She stopped follow-ups. Continued supplements indefinitely, just to be safe. Months later, she had stomach pain. Tests showed rising iron stores beyond what her body needed. Iron had helped her heal. Now it was irritating her system. Stopping at the right time is just as important as starting. That balance, start, adjust, stop, is where medical guidance matters most. This is one of the most common questions patients ask. How often do I need blood tests? There's no single answer, but there is a pattern. Common practice after treatment. Every 4 to 6 weeks during active correction, every 3 months once stable, then spaced further apart if no risk factors remain. More frequent if blood loss continues, chronic disease is present, pregnancy, surgery, or heavy periods exist. Less frequent if cause is resolved, stores are replenished, diet and habits are consistent. This isn't rigid scheduling. It's responsive care. Pray as HB normalized. Everyone celebrated. But her ferritin stayed borderline. Periods continued to be heavy. She felt okay until one stressful month tipped her balance. HB dipped again. This time it was caught early. No transfusion. No emergency. Just a course correction. That's the power of monitoring. Not drama, prevention. When anemia returns, people blame themselves. I must have eaten wrong. I didn't take enough supplements. I messed this up. That guilt is misplaced. Anemia is often a system issue, not a willpower issue. Blood loss, inflammation, hormonal shifts, chronic conditions. Monitoring isn't about mistrust. It's about respecting how complex the body is. Rachel didn't hate doctors, she just hated hospitals. Once she felt better, she vanished. No tests, no follow-up. When she returned months later, anemia was deeper and harder to correct. Not because treatment failed, but because nobody was watching the slow drift. That's the quiet danger. Recovery doesn't collapse, it erodes. Something important happens at this stage. The spotlight moves, doctors still guide, but the patient becomes the early warning system. Noticing, fatigue creeping back, breathlessness returning, concentration slipping. Those signals matter, especially when paired with labs. Recovery becomes shared responsibility, and that's not a burden. It's empowerment. If you step back, a pattern emerges. Treatment stabilizes, food sustains, Monitoring protects. Miss one and the structure weakens. This isn't about fear, it's about awareness. And now with numbers watched and habits in place, there's one final layer left. The long view. How to stay out of this cycle permanently. How to protect yourself during stress, illness, or life changes. How to stop anemia from quietly rewriting your story again. That's where everything finally comes together. Anemia doesn't usually come back with a warning. It comes back when life gets busy and attention drifts. Staying well isn't about fear. It's about staying one step ahead. By now, the noise has faded. No emergency numbers, no urgent decisions, no dramatic interventions. Just life returning to normal. And that's the most dangerous moment of all. Not because something is wrong, but because everything feels right. Recovery, at this stage, isn't loud or visible. It's maintenance, it's awareness. It's small choices repeated without applause. That's how anemia stays gone. Doctors often fix the immediate problem. They don't always get time to talk about the future. So let's do that here. Long-term stability depends on 3 quiet principles. Knowing your personal risk, respecting stress periods, avoiding overcorrection. None of these require perfection. They require honesty. Some people recover and never see anemia again. Others live closer to the edge, not by fault, but by biology. Higher long-term risk includes heavy menstrual bleeding, pregnancy and postpartum periods, chronic inflammation or kidney disease, thyroid disorders, digestive conditions affecting absorption, strict vegetarian or vegan diets without planning. This isn't destiny, it's context. When you know your risk, you don't panic, you prepare. That preparation is what turns relapse into a minor correction instead of a crisis. Nancy didn't become anxious after recovery. She became attentive. When tiredness felt different, deeper, heavier, she noticed. When stairs felt harder again, she didn't rationalize it away. She didn't rush to conclusions. She simply checked. And that one habit changed everything. She once said, "I stopped asking, am I just tired?" and started asking, "Is this familiar?" That awareness is powerful. Here's something rarely explained clearly. Even after full recovery, there are moments when the body becomes vulnerable again. Illness, surgery, pregnancy, major stress, rapid weight loss, long-term infections. During these windows, iron demand increases or absorption drops. This is when doctors often recommend temporary supplementation, closer monitoring, dietary tightening, not forever, just strategically. A 2022 clinical overview in the Lancet Hematology emphasized that anticipatory management during high-risk periods prevents recurrence of anemia. It's not about living cautiously. It's about timing support wisely. Priya didn't stop living fully after recovery. She traveled, she worked long hours, she managed family responsibilities. But she learned to plan. Before stressful periods, she checked her levels. After heavy cycles, she adjusted intake. She didn't wait for exhaustion to force action. That's the difference between reacting and managing. Life doesn't need to slow down. Awareness just needs to speed up slightly. This part surprises many people. Once someone understands anemia deeply, they sometimes swing too far the other way. Constant supplements, frequent unnecessary tests, anxiety around every tired day. That's not recovery. That's living under the shadow of the past. Excess iron can irritate the gut, increase oxidative stress, accumulate unnecessarily in tissues. A 2020 review in Hematologica clearly stated that iron supplementation should be reduced or stopped once iron stores normalize, unless ongoing loss exists. Healing includes knowing when to let go. Helen found a middle ground. She didn't forget anemia, but she didn't center her life around it either. She followed 3 rules. Annual checks unless symptoms appeared, short-term supplements only when advised, diet as a base, not a cure, and she trusted that framework. That trust brought calm. Normal doesn't mean never tired. Normal means fatigue matches effort. Breath returns quickly after exertion. Concentration doesn't drift constantly. Recovery after stress feels reasonable. Normal feels proportionate. When things feel off, not dramatic, just wrong, that's information. Listening early prevents escalation later. Rachel's 3rd visit changed him. Not because treatment was different, but because her mindset was, she stopped disappearing. Stopped self-adjusting. Stopped assuming better meant today. His anemia hasn't returned. Not because he's lucky, but because he stayed engaged. Consistency, not intensity, broke the cycle. If you've stayed this far, something important has happened. Anemia stopped being mysterious. Stopped being frightening. Stopped being something that just happens. You now understand why treatment choices differ, why speed isn't always safety, why food supports but doesn't replace care, why monitoring protects progress, why long-term awareness matters, that understanding is freedom, not from responsibility but from fear. Hemoglobin doesn't define your strength, but respecting it protects your future. Recovery isn't a single moment. It's a relationship with your body that gets quieter and steadier over time. If this series helped you understand your health more clearly, stay connected, ask questions, share your experience. Because informed patients don't just recover better, they stay well longer. Stay curious, stay aware, and stay well